Welcome everyone to this patient-focused webinar. I'm Katie Davis from InsightTech, and I'm pleased to be part of today's virtual educational event. Please be patient as we take a few minutes to allow everyone to get signed on. The presentation will begin shortly. Good afternoon and welcome everyone to this patient-focused webinar. I'm Katie Davis from InsightTech, and I'm pleased to be part of today's virtual educational event. Please be patient as we take just a few minutes to allow everyone to get signed on. The presentation will begin shortly. Looks like we have a good number of attendees sign on, so let's begin. The goal of today's presentation is for educational purposes. We are very fortunate to be hearing from Dr. Krishna and Dr. Roque from University of North Carolina at Chapel Hill as they discuss treatment options for essential tremor, and this talk is specific about the treatment day. As questions arise during the presentation, please utilize the Q&A button located at the bottom of your screen. We'll have time after the presentation to answer the questions that are asked within the chat. Let me begin by introducing you to today's presenters, Dr. Krishna and Dr. Roque. Dr. Krishna is a board-certified neurosurgeon with expertise in functional neurosurgery and neuromodulation. Dr. Krishna treats patients with movement disorders, including essential tremor, Parkinson's disease, and dystonia. He is an early adopter of focused ultrasound technology and is considered a thought leader in the field. As a surgeon scientist, he focuses on research to optimize the focused ultrasound technique to improve patient outcomes. Dr. Roque is a board-certified neurologist and movement disorder specialist with specific expertise diagnosing and treating multiple tremor syndromes. His clinical and research focus is on the improvement of tremors through both traditional and innovative methods, seeking out quality of life initiatives for patients with movement disorders. He serves on multiple regional and national forums aimed to improve outcomes for tremor management. Welcome, Dr. Krishna and Dr. Roque, who will be joining us here in a little bit, and thank you for presenting this afternoon. The floor is all yours.
Thank you, Katie, for this opportunity to connect with our patients through this educational webinar. I'm excited to be here with my partner in neurology, Dr. Roque, and members of our clinical team, Kelsey Workman, and research team, Marianne Barnett. And we would love to talk to you about essential tremor. And as you know, this is a 4-part webinar series. And we have talked about different topics all different days. In last 2 webinars, Dr. Roque went into great details about the diagnosis and the treatment of essential tremor. And in the last webinar, talked about the occupational therapy and other supportive treatment options for patients with tremors. Today, we are bringing the discussion around focused ultrasound and how does a treatment day look like for patients who choose to undergo focused ultrasound ablation. So it's a 2-part talk. The first part, I'll talk about the treatment day. And then in the later part of the talk, Dr. Roque will talk about the overall department here at UNC that helps take care of patients with tremor and other movement disorders. We want to keep it a more discussion type of a forum, and so you will see me and Dr. Roque discussing various aspects of the treatment with help from these slides as well. And you're welcome to ask questions, and Katie has kindly agreed to help by moderating some of the questions, and so that we can help answer these questions some of these as we go along and some of these towards the end. And so we want to start by talking about, what this technology is. And so as you all know, focused ultrasound technology involves delivery of ultrasound using this equipment we call the transducer. And this transducer has about 1,024 different little beams of ultrasound that are organized in a helmet-shaped structure. And this helmet sits on patient's head during the treatment. I'll show you in a video in a little bit. And each one of these ultrasound beams by itself is harmless to the brain, but when 1,000 of these combine together at a single spot in the brain, they are enough to increase the temperature and allow us to make very selective targeted ablations in the brain to treat patients' symptoms. This technology is paired with MRI, and so using MRI, you can then look at patient's brain anatomy, and not only anatomy, but also look at the temperature as we deliver ultrasound to see how the temperature rise looks like and how the tissue responds to the delivered ultrasound is. And so you could, in real time, know where you're making this ablation and how does the ablation look like, what's the extent of this ablation and such. And so this is a very powerful integration of ultrasound with MRI technology. Now, why some patients may prefer it, we talked about this part earlier as well, and it's an incision-less treatment. The results are immediate. It doesn't require implanted hardware, does not require any long-term programming. It's FDA approved currently for essential tremor. And as you may know, that it's also approved for treatment on both sides for essential tremors, treating both side symptoms, although the treatments are separated by about 9 months apart. That allows us to do it safely on both sides of the brain. It's also FDA approved to treat tremor-dominant Parkinson's disease fluctuations, and Parkinson's disease dyskinesias. And so you can treat quite a few symptoms of both essential tremor and Parkinson's disease with focused ultrasound. Now, so far, what we have discussed is that since we are focusing our discussion on essential tremor, that patients who have been diagnosed with essential tremor by our neurology colleagues and who have tried medications. Propranolol and primidone are the first-line medications, and preferably patients would have tried both, at least one of these with appropriate dosage, making sure that we have used the medicines enough to control the tremor. Sometimes the higher dose of medicines can cause side effects, and certainly we do realize and recognize that not all patients you can try these medicines to the highest possible dose, and that patients are reporting that the symptoms of tremors are now disabling, and that prevents patients from doing certain life activities, including activities of daily living like feeding yourself, writing, typing, hygiene activities, putting on makeup, and certainly not just limited to these activities, but also activities that involve your hobbies, playing golf, or other activities that involve fine motor work, for example, woodworking and such, are also considered in this assessment. And that patients are medically optimized from the standpoint of their heart function, their lung function, the kidney function. Physical health is optimized, that they are nutritionally in a good state, their balance is good and such. And mental health is optimized as well when we consider patients for this treatment. And then again, this is a flow chart that we want to present as to how the journey looks like for a patient who's undergoing this procedure. And so the referral comes in from neurology colleagues, either within the UNC system or from outside, to our UNC Health, and then we schedule an appointment with neurosurgery or movement disorder neurology, where we can get into the clinics first, and then make an assessment, and then we send the patient to our other colleagues and also order studies that may be needed for screening, like neuropsychological testing if it's indicated, If it's not indicated, then not. And then for focused ultrasound, we then also do the CT scan of the head to look at patient's skull and make sure that the skull is appropriate for patients to undergo focused ultrasound ablation. And once this is done, we make sure that we do this in an interdisciplinary fashion, that both neurology and neurosurgery have seen the patient and made a determination that someone is a good candidate to undergo focused ultrasound ablation. And once this is done, you're contacted by a surgery scheduler, find a surgical date, and then, if patients require a preoperative assessment to make sure that their heart function and their lung function or the diabetes is under control, then those are scheduled. And then we schedule a MRI of the brain, which is a high-resolution picture of the brain to understand patient's brain anatomy. And I'll show you some of the pictures in just a little bit that allows us to really understand where the spot in the brain is where ablation could result in tremor improvement. Once this is done, then your surgery date is scheduled, and then you come in to get your ultrasound treatment. And then once the ultrasound treatment is done, we do the imaging of the ultrasound ablation to understand where that is. And finally, you are scheduled for follow-up appointments. And this whole process takes some time. And so depending on what stage you're at, it may take 1 to 2 months overall in terms of the assessment. So it's a process, and there are ways where we could bring together the visits that are together so that we reduce the travel burden and allow you to minimize the number of visits while having the maximum assessment done so that you're ready for the treatment and undergo the treatment in a timely fashion. Now, while we are talking about the day of the treatment, few things just before the treatment, we request you to stop any blood thinners 7 to 10 days prior to your surgery. And these include a variety of these medicines that are listed here, including medicines we call NSAIDs like ibuprofen, naproxen, and then also clearly things like Coumadin, aspirin, or Plavix as well. Nothing to eat or drink after midnight. We then request you to be off of medicines at least 12 hours prior to surgery, because we would like to see your tremor during the treatment so that we can then titrate the treatment parameters and make sure that we get the maximum tremor relief with the treatment parameters. And on the day of treatment, there are basically 4 major steps to this treatment. The first step is the patient preparation stage, where we do a head shave of the entire head and then put a head frame that allows us to keep your head steady during the treatment. The second phase is the planning phase, where you are in the MRI machine and we are acquiring MRI of the brain to learn about the brain anatomy in real time and use this information and the information that we acquired from the previous high-resolution MRI, combine them together to figure out the exact spot where we are going to be delivering the ultrasound energy. And so with this part, in the first 15 to 20 minutes of your treatment, you're laying in the MRI while we acquire these live pictures and do the planning. The third phase is called target verification. This is a very critical step. Dr. Roque and I are very hands-on with this step, where we deliver small amounts of ultrasound energy to test whether delivering ultrasound causes patients to have any side effects and to understand how their tremor is improving or not improving. This really allows us to know whether the target that we have selected is going to be effective for you, is going to be safe for you. And if it is safe and if it is effective, then we move on to the next step, which is the treatment step, and call this ablation, where we increase the ultrasound parameters, treatment parameters, and deliver high-dose ultrasound to make the ablation and make the treatment effects permanent. And so you get tremor relief at the end of the treatment, and we want to make sure that this tremor relief is long-term. So this is a overall broad overview. And each one of these steps, so the prep step is about 20 to 30 minutes. Planning is about 15 to 20 minutes. Target verification is about 10 to 15 minutes. and the treatment is again about 10 to 15 minutes. And so overall, from start to finish, this is almost like a 3-hour timeline from where you start with the head shave and end with coming out of the treatment with tremor relief. And so that's the overall how a treatment looks like. And I have a video that goes into some of the salient features of this. A few points that I want to make sure: your entire head is shaved in the morning of the surgery. And it's important because what it allows us to do is to have a uniform flow of water on your head so that the water acts as a coupling medium between the ultrasound transducer and your head. And if the head shave is not done properly, then you can have turbulence in water, and the ultrasound system doesn't like that. And so you have to have a nice head shave before the treatment. And then we attach a head frame, which looks like a football helmet that we use numbing medicine, 2 parts in the front, 2 parts in the back, and use these pins to allow you to attach the head frame so that then the head frame is able to keep your head steady during the surgery. And the third point that we want to mention is that the treatment is done while you're awake, and this requires an active participation by the patient. Dr. Roque tests the tremor, tests for side effects, and does a variety of these activities to make sure that the target is verified before we do the permanent ablation. Dr. Roque, if you'd like to talk about any of these points, you're welcome to do that.
Sure, and hello everyone. Good afternoon. You know, and I'll maybe marry this with the previous slide in terms of what we're trying to do here. Accuracy is really defined in our mind as a combination of getting proper tremor control, but also really trying to avoid those side effects. Because it's one thing if, as we'll learn later, the side effect is related to some swelling, but if it's because of an area that we're about to heat up and burn, we really want to get away from those places that are very close together. I mean, these are an order of millimeters apart from each other, so very tiny spaces. But thankfully, the way that we perform the procedure, what we're going to burn should also be millimeters in size. So it should be all very, very small efforts to get the best tremor control and really get around those side effects. You heard Dr. Krishna say just in the last slide that with the target verification, you know, we're looking for that, right? We're heating up before we actually burn anything in order to find out what benefits and what side effects we're getting. If it turns out we're getting some side effects, we have the option to move the location that we are trying to heat up. So we're not just stuck. In case anyone was wondering, like, we're not stuck. We can absolutely move the location. And in fact, that's very typically what is performed here and later as we start doing the true you know, lesioning component. That's what I have.
That's a great point. And so the point to be stressed here is tremor relief without side effects. That's the goal, and can't overemphasize how active participation by patients and very careful thought process and discussion by the treatment team goes a long way in getting good outcomes in patients undergoing focused ultrasound. And so it's a team sport, and we are all on your team when we do the treatment. And the idea is to have maximum tremor relief without side effects. So I have a video that's about 2.5 to 3 minutes, and what we'll do is I'll pause the video a few times as well to show you some of these salient aspects so that you can visualize how that treatment day looks like and what we are doing behind the scenes so that you have a better understanding of the overall workflow. And so, as you all know, focused ultrasound is an FDA-approved treatment for essential tremor for Parkinson's disease. And essential tremor, you can now treat both sides of the body 9 months apart. And for Parkinson's disease, you can treat Parkinsonian tremor only on one side, fluctuations and dyskinesia, again, only on one side of the body. I'm sorry, this is... and this treatment can be done as an outpatient treatment, does not require surgical incisions, and we only deliver local anesthesia to place the head frames. And as I mentioned before, the effects are immediate. And this is how the arrangement looks like that we've been talking to you about, where patient, you know, we have this carton, you know, showing the patient positioning, And you can see that the part of the head frame here is highlighted in green. So this is the head frame that allows us to keep your head steady during the treatment. As Dr. Roque mentioned, it's a game of a few millimeters here and there, and so we have to be extremely precise with this treatment. And once the head frame is in place, then we bring the ultrasound transducer. I'm sorry, this ultrasound transducer, which is then highlighted in the green right there. So this is the ultrasound transducer. You can see it's positioned above patient's head. And then there is a membrane you can see right here with this white color, grayish color right there that is then filled with water. And the water acts as a coupling medium between the ultrasound and patient's head. And so that's how the overall arrangement looks like. And once the ultrasound transducer is placed on patient's head, then all efforts are then directed towards making sure that patients are comfortable inside the MRI, because you'll be laying there for about an hour and a half or so while we do the treatment. And so we make sure that your back is not hurting and that you have enough support underneath your legs and such to make sure that your treatment your comfort is maximized during the treatment. While you're laying in the MRI machine and we are doing the planning phase, we're looking at a variety of different parameters to then understand how the treatment would go like. And some of these parameters of interest for us include, number of elements. As I talked to you about, there are 1,024 different ultrasound elements inside the transducer. And on the right-hand side, you can see the picture of the ultrasound transducer, and it can give us a snapshot as to where the ultrasound energy is going to be delivered from and how the overall organization will look like. And then the other thing that we are interested in is understanding the skull area, how much area of the skull is available for us to do the treatment. And finally, this thing called skull score. You must have heard about that your skull needs to be the appropriate type for the ultrasound to go through it efficiently. Sometimes the skulls are too heterogeneous and the ultrasound doesn't go through the skull as efficiently, and so the treatments are not efficient. And I don't want people to worry about it. It's not about the thickness of the skull. It's not people who are hard-headed have a hard time getting the ultrasound treatment. A lot of my patients become concerned, am I too hard-headed? No. It's a lot more about the heterogeneity of the skull and how it looks. And so a skull score of more than 0.4 is excellent for ultrasound. And as you can see in this case, it's 0.55, and that helps us then to do the treatment efficiently. Once we are done looking at these kind of treatment parameters, then we decide about what initial dose of ultrasound we're going to prescribe to then allow us to make the initial target verification. And this is how a treatment window looks like. And I know there's a lot of information here, but in the center screen, this red dot is where you can see that the ultrasound delivery resulted in slight temperature increase. And then you can see that we prescribed some energy of 3,000 joules using these parameters, and that increased the temperature. And the increase in temperature, we are able to, in real time, visualize using this graph. You can see on the right-hand side, the maximum temperature of 41 degrees centigrade and the average temperature of 40 degrees centigrade. And so that temperature rises just enough for us to temporarily heat up the tissue and do target verification and do the testing. And so this then allows us to, in a very short amount of time, increase the energy, increase the temperature, and very quickly then we are able to do testing with these low energy sonications. Another pictorial showing ultrasound beams coming together in this target area right there, and enough energy to do testing. And so we go inside, and then patients are awake, and we're doing testing to make sure that the tremor is good and that the patients are not having any side effects. This is another good point. Dr. Roque mentioned that if you were to get into a side effect during this stage, then we can move the target as shown by the cartoon here. You move it to a safer location, and then you can repeat the testing one more time to make sure that you're in a safer location. And so you have the ability to do these fine adjustments during ultrasound. Once we are convinced that it's a safe location and the patient's tremor is going down, then we can increase the ultrasound energy. As you can see, we increased from 3,000 to 13,000 joules. And then the temperature here increased to 63 degrees centigrade. And that allows us to make the ablation permanent, and then patients can have long-term improvement in their tremor, and then that these long-term symptom reliefs they can keep over time. And overall, you'll be surprised that in the short amount of time that ultrasound has been found, more than 10,000 patients worldwide have had ultrasound ablation. And the results are fantastic, and a lot of patients have benefited from this treatment, are able to get back into activities and reconnect with parts of their lives that they had been missing because of the tremors. So that's the overall, how the treatment day looks like in a video in a nutshell. Dr. Roque, I'm going to take a pause here and would love to hear your thoughts. You're an integral part of the team, and so there are points here that they would like to mention.
Yes, so I think the big take-home points here, as I think you're starting to appreciate, this is a very viable option for folks to look into when your goal is to find among the best options available to really control your tremor. We know that there are impacts from things like medication, and we talked last time about occupational therapy efforts to really just try to get a handle on specific activities that your tremor is being impactful upon in a negative fashion. But when you're really trying to get that fine tuning, and yes, these are not cures at the end of the day, but when we're trying to get a significant reduction in the tremor, such that you really are hopeful to get into some of the finer details that you just haven't been able to pursue because of your tremor for months, years, maybe decades. These really are, with a safe and successful procedure, we really can get there. And again, it's not a cure. I wouldn't necessarily say that it's commonplace that it absolutely goes away, but gosh, does it improve by a significant percentage that we otherwise just couldn't hit with any of the more traditional or conservative approaches. To boot is that, for those who know anything about the history of how we even got here, we really go back to the 1890s, and I did say 1890s, and you kind of move your way from animal research into people getting surgeries where we were performing ablations in a very different way, where we didn't have this kind of technology. And so those were at this point considered archaic, but nowadays we're kind of returning to some of the important features of what we knew from back in those days, but really doing it in such a precise way. And we have, the proof's in the pudding. We're showing it is possible to really keep away from those side effects in a meaningful way, yet get the benefits that we know we even saw back then in terms of tremor control, but arguably better just because we can do it in such a safer format. So I think that's a nice summary plus of kind of where we've been and what we're aiming to achieve.
Yeah, so this is a great segue into what Dr. Roque here mentioned. And so we can't overemphasize how these areas of the brain that improve your tremor and the ones that can give you side effects are very close by. And so this is actually a picture from one of our patients. And what we are showing here, different views of the same location, where this area in the green that you see is the target for tremor surgery. We call this area the VIM nucleus of the thalamus. You would hear this term again and again, VIM nucleus of the thalamus. And this area we think seems to be involved with tremor very intimately. And so every time when we do, say, deep brain stimulation surgery or focused ultrasound ablation, this is the area that we are targeting with our surgical interventions. And the yellow is the ablation that we made in our patient to achieve a reduction in their tremor. And so the yellow area is the ablation with focused ultrasound that allowed us to do the ablation and reduce the tremor in that patient. You will appreciate that the area in the red, which is very close to the yellow area and the green area, is the part of the brain that controls strength, motor strength, muscle strength in arm and leg. And any ablation of this area can cause weakness in that body region. So again, an area which controls the strength of muscles in arms or legs and can cause weakness is very close by. Not only this, there is an area here in purple that we are showing, which is the sensory area of the brain, and any ablation into this area can cause loss of sensation. And so especially sensation around the face, sensation in the hand. And so you will appreciate that the areas that control movement and muscle strength and the area that controls sensation are exactly very close, within a few millimeters of where we need to make the ablation for it to be maximally effective and reduce patients' tremors. And so that's the goal overall, improve tremor without risking side effects. All right, there are a few considerations. Post-op patients ask this question, and so these are some of the main ones, and I'm sure that Kelsey would look at this and she would say, oh, no, you missed 4 or 5 more of these. But I just want to give folks an overall idea. And so there are some activity restrictions. So even though you don't have incision, you don't have signs, outside signs of surgery, patients who undergo focused ultrasound have had a brain operation done. And so there are some restrictions that come with activity. So we recommend that you rest and relax for the first 2 weeks after surgery and avoid any activities that tire you out. We consider those strenuous activities. We would even, recommend you to avoid even light activities for the first 2 weeks. So like light household work, just for first 2 weeks, I'd tell my patient, be a couch potato and enjoy that life for the first 2 weeks. After that, you can slowly start to engage in these activities. And then heavy activities for the first 4 weeks. So I would avoid jogging, swimming, mowing the grass, and these kind of things for the first 4 weeks after surgery. No driving for the first 4 weeks. And then you can gradually increase your activities, after 2 weeks and see how you do with it. And then based on how you're feeling, then you can continue to go up. Now, overall, I just want to bring together some of the expectations that come with it. And so we are talking about tremor relief. And so we expect about a 60 to 70% reduction in tremor. And I would even venture to say that, depending on where the treatment is headed and how safe the area for ablation is, I would even say 50 to 70% reduction in tremor is what we aim for in patients who undergo focused ultrasound. The most common side effect that we see is ataxia, which is this idea that patients have some difficulty in balance or coordination, especially if they had this before surgery, because a lot of our patients with tremor can have impaired balance, and this can get worse after the surgery. Dysarthria is another side effect that we see, which is a difficulty or slurring in speech, a difficulty in pronouncing certain words. And so that's, again, seen more commonly in patients who have this to begin with, and can get worse after the treatment. Swallowing difficulty, again, we see in patients who have had swallowing difficulty to begin with, it can get worse after the treatment. And so certainly that's something that we look for and make sure that the patients, if they have it, that it's appropriately managed as well. And the other piece that I would mention to you is that a lot of my patients with tremor say if they are right-hand dominant and they start to have tremor in the right hand, they start to rely quite a bit on their left hand. And eventually the left hand also gets tremors. After treatment, you have to almost retrain yourself to pay attention to use your treated hand again. And so it's a matter of some conscious thinking and bringing that treated hand into motions and movements. The other aspect is that a lot of my patients then develop this adaptation to use both hands to do activities. But once you have had the treatment, you can then relearn to trust your treated hand and take the other side, which is still having tremor, out of the equation, so that you can take the maximum benefit out of the treatment. So a lot of these side effects, they get better over time, a few days to a few months. Some patients even require some physical therapy as well to improve their imbalance. And then we talked about some of the side effects. They can get worse if you have those baseline. And so that's the overall expectation piece. Now, all of us have, this thought that we should go through the treatment as smoothly as we can. And over time, we have looked at certain factors that delay our patients' care. And so I want to highlight those so that we are aware of these. And if we identify those, then we are proactive about managing these. So uncontrolled hypertension or uncontrolled diabetes. So certainly we look for a hemoglobin A1C of less than 7. These are sort of indicators of good health. And typically you would want patients to be in good health to heal from this. And so don't want to do surgery when your blood pressure is out of control or diabetes is out of control. If the weight limit on the ultrasound table is no more than 290 pounds, so if the weight is more than 290 pounds, that's a hard stop. And so if that's something that folks can start working on ahead of time, that would prevent any delays in care. We talked about skull density. So if the skull is too heterogeneous, then unfortunately this treatment cannot be done. If you have implanted MRI incompatible pacemakers or other devices, then that becomes an issue in undergoing this treatment. And then in some of our patients, stopping the blood thinners is too high risk. For example, if you've had cardiac stents within 6 months, or if you had recent blood clots in your lungs and such. And so then we wait out and then make sure that it's safe to stop anticoagulations. Another area is difficulty in social support. So in the first few weeks, you would need someone around the house to make sure that you're doing okay. And so if that's difficult, then arranging for that can sometimes take time. And then mental health challenges, for example, uncontrolled depression, uncontrolled anxiety, those could be issues as well. Active smoker, we are very strict about that. And so we at least quit smoking 2 weeks before, 2 weeks after. But in general, it's best not to smoke during the pre-surgical times. And then if during the workup, pre-treatment assessment, we realize that patients have difficulty in clotting their blood or have other blood-related disorders, then that becomes a cause for delay because these need to be managed before we can jump into treatment. And this is the information for the referral for the neurology clinic, Tremor interdisciplinary clinic, and the neurosurgery clinic as well. And so these are good phone numbers for patients to have. And what I'll do is I'll come back to the slide and share these numbers with you so that you have these numbers if you need them. And we are happy to take questions. And I'll keep the slides on the referral information.
Awesome. Thank you guys so much for another awesome webinar in this series. We do have a couple questions keyed up, and if you have questions for either Dr. Krishna or Dr. Roque, please utilize the Q&A button located at the bottom of your screen and we'll get started. One of the questions that was asked that I typed in an answer earlier, but just in case other people are wondering on the webinar, there was a question about whether this webinar is being recorded and able to be viewed later. So this webinar, as well as the 2 previous webinars in this series, have been recorded and they're actually available on the UNC Neurosurgery YouTube channel. So this one I would anticipate would get up by the end of the week. And in the meantime, you can look at the other 2 if you happen to miss those. So I just wanted to make sure that everyone on the webinar knows about that, since that question was, I typed the answer privately. So then here is our first question. What if someone can't have an MRI because of a bone replacement with a wire about 45 years ago?
Yes, so certainly, as we mentioned, there are certain situations where you cannot have the MRI done. And then that becomes a concern, and we are not able to do the treatment because this requires MRI guidance, live MRI guidance for this. But in this specific question, I would mention that it may be wise to really understand whether they can get the MRI or not. Because usually someone who has had surgery done 45 years ago, a lot of MR centers are able to do MRI without an issue. And so this is certainly something that can be looked into, and I don't see this to be a complete no-no for getting the treatment. This should be okay.
Yeah, and you touched on that, but I'm gonna, because a lot of times we get about a pacemaker or they have a stimulator. There is probably one exception if they had already had DBS prior. So maybe explain, if you have some hesitation, reach out to this team. They're happy to do the research, connect with the manufacturer, whatever type of stuff is in your body to confirm that. But can you talk a little bit about focused ultrasound before DBS or DBS before focused ultrasound and how that kind of works?
Yeah, no, certainly that's a great question, and Dr. Roque and I are both happy to answer that question. And so certainly the approach that we have here at UNC is to do a multidisciplinary assessment where we sit down with the patient and present both options and go into the details and then discuss about what each treatment has to offer, what are the risks and what are the benefits. And the key in our minds is to figure out what the goals for the patient are, and so what they're trying to achieve, and then marry the best treatment with the goals of the patient. In general, you can have DBS after a focused ultrasound procedure, but you cannot have a focused ultrasound if you already have DBS in place because of the risk of metal being in there. And so I'll stop it at that, and I'll have Dr. Roque answer that question as well.
Yeah, no, I mean, that's spot on. The key factor there, which, since I think the original question is just more about any other implantable hardware, we're just distinguishing here about deep brain stimulation surgery. That history of having had it, it's just not safe to do. There's, the thing that comes into question occasionally, and we end up certainly reviewing this on a case-by-case basis, is if someone had DBS and had their hardware completely removed, is this still an option for you potentially instead of going back and doing DBS? Very case by case, because we have to be very thoughtful and careful about where you had wires before, and whether, I mean, goodness, thankfully it's very uncommon, but being sure that all hardware has in fact been removed, because there's always a possibility of something that has stayed behind for some practical reason. But if we're in a position where you have an active piece of hardware, we just can't safely perform this inside of your skull.
Awesome. This is another question I hear a lot. So what about people who are claustrophobic and have difficulty being in the MRI? Can something be given to relax them, a sedative? Do you do that? And if not, can you explain the rationale behind any of that?
That's again a great question. And so claustrophobia is a condition where, when you go inside the MRI, then it becomes, anxiety provoking. And interesting thing that we have noticed is that there are degrees of claustrophobia. And so for some patients, it's uncomfortable, but they're able to push through it. For others, they require a medicine, and for some others, it's a big no-no. And so all claustrophobia is not the same, and so it comes in different flavors. And certainly, as a part of our assessment, then we assess, what degree of claustrophobia you have. In general, we can give some medicines to help with some of this. But in general, we don't want to give a lot of medicines to take away anxiety, because what that does is it takes away your tremor as well. And so it's taking away from us a major real-time guidance to make this lesion safely, to make the ablation, to have long-term, long-lasting tremor relief. And so we are hesitant in terms of giving a lot of medicines because they could cut down on your tremor as well. But sometimes we're certainly happy to look at what can be done to help with the claustrophobia. The most important thing folks need to know is that it's not that you're laying inside the MRI machine for the full 2 hours of the procedure. At the most, you are inside the MRI machine for, say, 10 minutes or so. And we are coming in and out. And so we take you out of the MRI, do the testing, and then we do some more images, and then we take you out and do some more testing, or we do some target verification stage and give you some ultrasound. And so you're coming in and out of that MRI magnet several times over the course of that hour and a half. And so something to keep in mind.
No, that was going to be my follow-up about in and out. So go ahead, Dr. Roque.
Yeah, and I was just to follow up on that, because I think it'll help touch on another similar question that's a little further down the line. We've dealt with this in the focused ultrasound realm, in the deep brain stimulation realm for quite a while. And we've tried any number of things to help folks calm down, to reduce anxiety. And what we find is invariably we are always negatively impacting the appearance of that tremor, meaning it starts to wash the tremor away, and it makes it feel like we've already treated it, even though we haven't done anything yet, right? And it's a real false sense of security on that end, and a real burden for us to then try and figure out, are we getting this right? Are we actually going to make a meaningful impact on your tremor? And this is even more crucial in focused ultrasound, because in deep brain stimulation surgery, at least we're listening to your brain, so we get some feedback about what's happening in there. But we are just watching, what's happening to your tremor in focused ultrasound. But the point Dr. Krishna makes is also crucial. How much time are you spending in the scanner really, is only so long. But if you're also going to be claustrophobic, because I know there was a comment about being strapped down, your head is effectively strapped down because of this head frame. So you may be out of the scanner, but if it's uncomfortable to have this held to a bed where you're really not able to move, this might be tricky to really complete for you. We wouldn't exclude it entirely. We can have that conversation, but at the end of the day, like we've been saying, we really want to minimize how much we're introducing other variables we're introducing that could, again, give us that false sense of security.
And that same person is talking about laying still, and you just touched on that with me, or with it a little bit, in the fact that that's part of the reason that they're in that halo device, so that the part that you guys are treating is still. I've been in treatments where there's other, anxiety with like restless leg and stuff, and that doesn't seem to affect our treating team. Can you talk about that? So they might not lay, I don't know how to say it. Are they going to have to absolutely lay completely still? No, you can't move a muscle, hold your breath, or kind of explain the transducer and the head frame?
Yeah, I think I can start with that. It really, perfectly still is a relative term, right? Perfectly still is what we're doing with the head frame, as perfectly as we can. The rest of your body is laying. I mean, we're not restraining you as much as we're trying to keep you comfortable and very much sort of we'll call it a cocoon within the bed itself, because it is also a radiology suite, so it does get cold in there as well. So we're just trying to keep you comfortable. And the testing that we're doing, bringing you out of the scanner, invariably you're going to be moving. So again, you're not truly restrained, other than perhaps the head invariably against the bed. I would say that generally we're trying to keep your core, your trunk, to feel as though it's largely not moving very much, because that, you can imagine, that has an impact on exactly where your head is located too. All the while, as Dr. Krishna alluded to earlier, trying to keep you comfortable the whole way through. So again, maybe perfectly still being a relative term is perhaps what we should be saying.
Perfect. So the next question is, will the tremor ever return? And discuss kind of long lasting. And one of the things that just for your guys' thing is kind of explain to them the difference between a treatment, which is what focused ultrasound is, and ultimately a cure for essential tremor, no matter what we do.
So certainly this is a great question, and that's an area of active research for all of us as well. And so in general, what we say is that, in some degree, tremor can come back after focused ultrasound treatment. And that's because as focused ultrasound treatment, our goal is to improve patients' tremor by 50 to 70%, and it's not a cure for tremor. So we are not curing the underlying reason for the tremor. We are just using this ultrasound beam, ablating an area of the brain that's causing the patient to have tremors. And so what we have noticed is that in some patients, in the long term, the tremor can come back. The longest outcome published in the literature was roughly 5 years or so. So up to 5 years, there is published data to show long-lasting effects in tremor reduction. The longest follow-up I have seen is roughly 7 years or so. And so patients have had relief in their tremors up to 5 to 7 years after treatment. And this is not to say that the tremor relief is not going to last beyond that. It's just that the technology is new and the follow-ups so far have been short. And in future, stay tuned and you will see things about longevity. Two other thoughts about longevity that I have are, one is that in some patients, the tremor comes back in a delayed way, let's say after 1 year, 2 years, 3 years. And in those scenarios, what we think is that it's likely a product of tremor progressively getting worse, patient symptoms or disease progressively getting worse. And so despite having that focused ultrasound ablation, then the tremors appears again as the disease progresses over time. Then the second thought is that in some patients, tremor tends to come back earlier, so less than 1 year. And in those scenarios, we see either it's related to the ablation not being big enough or large enough to reduce the tremor, or there is a component of healing, that kind of overtakes the effects of the ablation. And so we tend to classify this into two categories: those where the tremor relief sort of decreases within the year, and those where it decreases beyond a year, and then trying to separate that out. Dr. Roque, your thoughts on that?
Yeah, and Dr. Roque, if you can add one caveat to it with your explanation here. When you guys are talking about tremor coming back, are you referring to if I was one of your patients and I got focused ultrasound and I had 70% tremor reduction? Are you talking about a year, 2 years, getting all 70% back? Or can you kind of explain that too, with your thoughts from Dr. Krishna?
Yeah, I will weave that into my thoughts. So yeah, so
Perfect.
to really piggyback off of Dr. Krishna's comments here, one thing that many here may not even realize, because we've only been publishing this information for about 5 to 6 years, which means that we are way delayed trying to get this information out to the general public. But what is clear to us regarding essential tremor, especially, is that this is a condition that ultimately is progressive. What is the nature of progression is just depends on the person and factors that we don't know enough about. We've at least been honest with ourselves about this. We don't yet know what the variables are that impact how quickly you progress, how slowly you progress, where you progress. So that this is something we're not yet and haven't been really accounting enough for, because we don't really know how to account for it when we're studying tremor and the effects of treatment on tremor. So that when we talk about something along the lines of, percent changes, it's really going to be relevant, relative to what you feel as a person, right? What you have lost in terms of tremor benefits from the procedure, and specific activities perhaps. It could be about how big the tremor appears, but often it's more about the kind of activities you feel that you no longer could do that you were capable of after surgery. So I think it's less about a percent specific reduction or raising of your tremor. And also, this is, for those who know anything about the way we used to do these procedures before focused ultrasound, there were people who would lose the benefit. And as Dr. Krishna already mentioned, there are folks who do, and thankfully there could be, not always, but there could be an option to come back and do these again under the right circumstances. It's kind of like coming back to the fold and making sure we feel you're still a good candidate at the end of the day. But yeah, I mean, the longevity is, relative to what we know right now, as was already mentioned, the best sort of largest group data we have is mostly at 5 years out from surgery, showing how it still works 5 years out for a vast majority. But in the past, we do have information that might tell us that, you know, better than a quarter of folks might get return of tremor in the old way we used to do these. So the verdict is a bit still out, and we're still very much interested in following that over time.
Awesome. So a couple more questions, and then we can talk about the tremor interdisciplinary clinic and kind of go through the department slides. So first one, it should be nice and straightforward. When the skull score is done, the skull density ratio, is it done well in advance of the MRI, meaning getting focus ultrasound? Kind of walk through that that workflow, and I think it's a little bit in our slides as well.
So certainly it can be done ahead of the MRI for sure. You know, the first time you see us, and we could get the skull score. In a lot of our patients, though, it ends up in being simultaneous, and so where we put in a request for CT and the MRI, and then so that we minimize the number of trips for the patient when they see us. We put the CT MRI orders and get things going.
Perfect. So I'm going to kind of paraphrase these next couple of questions here. So this patient has essential tremor, and so did his father. His father had to retire, actually, and worked at Cap Lejeune for many years when he had to resort, because of his tremor, to eating with his hands before he died. Is there a connection, or can you kind of talk about the historical connection of what causes, or what you guys think, or research of causing essential tremor? Could it be linked to something like water, like they said? Is it hereditary? Because his father had it, but he also worked there during his teen years. So is it a hereditary connection? Is it something like that, even though we can't be definitive?
I'm going to be entirely as just objective as I can here about this information. We get a lot. You can imagine we work in the area. We get a lot of questions about Camp Lejeune and neurological conditions, multiple neurological conditions that may get raised as potentially linked with toxins and things of the nature that have arisen from the history, and it even goes beyond that. But the long and the short is, I think, to get to that bigger question, what causes essential tremor? We don't know. We don't know. We know that there are strong family ties, but we also meet plenty of people who don't have a known family history of tremor, but otherwise fit the bill. But then I think I mentioned it in one of the previous webinars, I've even had family in the same room who swear there's no family history. And because there's family, I ask if I may check them for tremor, and I find mild tremor in the family members. And I'm like, oh, guess what? It is running in the family. So it's you know, just being as honest with ourselves as possible. What we know is that it tends to be hereditary. I actually have colleagues who have tried to find the genes associated with this, and we cannot find the genes. There's too many potential options, and so as a result, it's not like a single thing we can study, unfortunately. And just to add insult to injury, I know there was a previous slide that I think is worth maybe clarifying on, which is that you know, the place we are targeting in surgery is a place that we think is mostly a relay station for the development of tremor. It's why multiple tremor types, we still aim for the same location to try and see if that helps reduce tremor. But as an actual causing place, if anything, there's more and more information suggesting that the causing locations in the brain are from other parts, especially the coordination center of the brain for essential tremor in particular. The coordination center of the brain being very important because, as Dr. Krishna mentioned earlier, we know we can inadvertently worsen coordination and balance issues with this procedure. And in fact, we just for the last 5 years have had a whole new label for essential tremor that we now call Essential Tremor Plus, where it's a label for us to know that you have more symptoms than just tremor, but we still think it's associated or otherwise related to your tremor. With perhaps the most common one being balance issues, coordination difficulties, et cetera. So still a lot of work to be done, and work being done. I mean, I have plenty of colleagues around the world at this point who are doing quite a bit of effort in different realms of essential tremor. And I'm going to say the word finally doing that work, because I think what most folks with essential tremor have felt, maybe even up to, although hopefully no longer, the last 5 years, is that there's a sense that there's not enough research, there's not enough effort to do better for this condition, to understand it better. But I can assure you there is quite a bit, and that is newfound for just the last 10 years. So hopefully the momentum will carry, and you'll have more to hear from us in the coming decade.
Perfect. That sounds good. And then we have a couple of slides that talk about the department and the treatment team, Dr. Roque, that you'd like to share. Is that right?
I think
Am I making this up?
maybe possibly a little bit, but at the same time, I'll give what I have, which I think is the same here. Let me see if I can share it. Hoping that's sharing okay. Yeah,
Yes,
so
perfect.
thank you. Yeah, so Dr. Krishna already showed this slide up there where, although it has a little more detail regarding what we do, this is a unique clinic that we have at UNC. It's first of its kind, as far as we're aware, and we looked. But in short, it is a morning where you get to come. It's very consultative based. The point is to get as much information as you can out of this clinic regarding your tremor, regarding the syndrome that is developing your tremor, maybe get some clarification on whether the tremor syndrome you have is in fact essential tremor related to Parkinson's, something else. There are other conditions that lead to tremor syndromes that don't have to be what we otherwise refer to as the big three. So trying to get some clarification there, learn about your surgical options when those are appropriate from Dr. Krishna in the same sitting, learn from our occupational therapist who helped me put that slide deck before for the previous webinar. She's tremor subspecialized, which is a thing in occupational therapy. So it's a wonderful thing to have her on board. And then we have a bigger team with nurse education. We actually have a biomedical engineering group who helps us come in and sort of on case-by-case scenarios, kind of give you some more quantitative information, right? Just numbers to work with about what, your tremor severity, where it seems to be coming from. And then there are research opportunities embedded within our clinic so that we get a chance to tell folks, if you are interested in research participation, what you might qualify for, and happy to push you sort of in the right directions there if you are interested. But that's the sense there. And otherwise, I think, oh yeah, so I mentioned this goal. It's really consultative. So we're hoping to get folks to really take the information and move to their local providers with that information to complete, a full occupational therapy, to consider medication changes, and then certainly from the surgical perspective, we're happy to help here. Sorry, happy to help here, but also want to be able to connect with your local providers, in that respect. And you already saw this slide earlier, although I think the number for Dr. Krishna's office, I may have this wrong. This might be a different number on this particular slide, but that's that.
No, and that's correct.
Is it? Okay, great.
Yeah, we have two numbers, this one and there's another one. So both are fine.
Both are fine. Okay, all right.
Can you talk about, I always find it fascinating, how long does it take a patient to get into that interdisciplinary clinic? You're talking specialists that across the country we hear are really hard to get in if you just try to get into them individually, let alone on a time like this. And how many places are doing something like this?
So we don't know of anywhere else that's doing something like this right now. We've already presented we'll call it the validity. So just, the rationale for having a clinic like this out to the international community. And there were some folks who I think were listening, but I still haven't heard of anyone developing something else like this elsewhere. And I do hope it eventually catches on and gets momentum, because we can't see every tremor patient in the world. But that said, for folks in the area, we certainly will see folks outside of the area. Again, it's consultative anyways, so we could still bring that information. You can bring it to your local providers, but right now we roughly are looking at about 2 months out, and I say that at the risk of getting bombarded with a lot of referrals to make that very different. But for the moment, it's about 2 months out, so it's not too bad. You're not having to look for a year plus just to be evaluated. And we hope to keep it that way because there is a little bit of a process for us to review requests where we want to make sure you're going to be able to get the most out of it. And then we don't want to assume that you want this. I mean, some of the docs who are out there who are referring patients to us, we talk to the patients and they're like, we had no idea that this is what I was being referred for. So we want to get that clarification and, bridge that communication gap across the board from getting the referral all the way through the recommendations that we're giving.
Awesome. Well, as always, that is all of our questions. Another wonderful presentation. For those of you, and I should know this, we have another webinar, our fourth one in the series, kind of summarizing everything we've talked about in March. So if you want to continue on this journey with us, sign up. Otherwise, they'd be happy to help or answer any questions with that email and phone number that was listed. Dr. Krishna, Dr. Roque, thank you so much. And for everyone who attended this afternoon and participated and asked questions, thank you for taking the time out to learn more about focused ultrasound at UNC. Everyone have a wonderful day.
Thank you, folks.
Thank you.